Hello everyone, in today's video we're going to be talking about a few pointers on the basic pathophysiology in APLA syndrome. That is nothing but antiphospholipid antibody syndrome. Before going to the disease proper, let's go to a few pointers of cellular physiology. As we all know, every cell is surrounded by a cell membrane, and inside the cell there is the nucleus which is containing all the nuclear material inside it, and there is one more powerhouse of the cell which is a kidney bean shaped organelle with all the powerhouse containing enzymes, that is the mitochondria. Every cell membrane is composed of certain phospholipids, and these phospholipids occur in the nuclear membrane also and the mitochondrial membrane also, and there are certain proteins which are bound to this phospholipids. Now, there are three main antibodies which you should be knowing about in the APLA syndrome. The first one is the lupus anticoagulant or the LAC, lupus anticoagulant. The second one is nothing but the anticardiolipin antibody, anticardiolipin antibody. And the third one is the beta 2 glycoprotein. Beta 2 glycoprotein antibody. Why we should know all this is, each of these antibodies affects a different part of the cell. The first, that is the lupus anticoagulant, mainly affects the phospholipid binding protein. Okay, this is what the lupus anticoagulant attacks. Next, the anticardiolipin antibody attacks the mitochondrial membrane, and the beta 2 glycoprotein also attacks the phospholipid bound protein. Whichever antibody is attacking whichever structure in the cell, it all leads to one main problem, that is cell death. Why cell death? Because once the membrane is damaged, all the cellular contents are exposed to the outside environment, which leads to cell destruction. Now, most of these antibodies attack what is called as the endothelial cells. Okay, the endothelial cells are the ones which are bearing the brunt of this disease, and hence all the endothelial cell damage which is occurring leads to various pathology. Now, whenever the endothelial cells are destroyed, what is exposed is nothing but the basement membrane. Now, exposure of the basement membrane to the outside environment leads to what is called as activation of the coagulation pathway. Okay, and it leads to platelet aggregation, and exposure to the basement membrane leads to release of various cytokines which triggers inflammation. And once inflammation is triggered, what does it do? It releases prostaglandins, mainly the PGE1, the PGE2 and the thromboxane. These are all derivatives from the arachidonic acid which are there in the cell membrane, and all of these increase platelet aggregation and stimulate or trigger the coagulation pathway by one way or the other. Now, the only thing which is not being triggered or increased by this is the PGI2. PGI2 is nothing but prostacyclin, and prostacyclin is decreased whenever endothelial damage occurs. What does prostacyclin do? Prostacyclin normally causes vasodilatation, but once the PGE1 is increased, PGE2 is increased, thromboxane is increased, and PGI2 is decreased, all of this, it helps in nothing but vasospasm as well as platelet aggregation. See, there is vasospasm, there is platelet aggregation, there is basement membrane destruction. All of this always points towards one common point, that is, they all form a component of the virtuous triad. And hence, virtuous triad, as we all know, is the basic or the basis for the formation of a thrombus. So this is how APLA syndrome causes thrombosis. Now, this thrombosis, this cellular damage, it can occur anywhere in the body. It can occur in CNS, leading to stroke, leading to seizures. It can occur in the peripheral vessels, leading to peripheral vascular disease, or it can cause thrombosis in the arteries, in the veins, in the small lymphatics, in the capillary system. It can cause various forms of vasculitis because of the endothelial damage. It can affect the kidneys or the renal system, leading to renal failure, chronic renal failure, acute renal failure of various forms. But most importantly, why is APLA so significant? Because it's a connective tissue disorder, we know there is a female preponderance. Okay, and more importantly, this thrombosis is seen as a bad obstetric outcome. Why is there a bad obstetric outcome in these patients? The endothelial cell damage and all the vasospasm and thrombosis can occur even in the syncytial trophoblast. And you know that the syncytial trophoblast is the basis of placental function. And once syncytial trophoblast is damaged, it can lead to adverse pregnancy outcomes in first trimester with early pregnancy loss, miscarriages. Early pregnancy loss is one, or a repeated early pregnancy loss is a feature, and it can occur in second trimester as well as third trimester as stillbirths, early onset preeclampsia, and it can also present with features of placental insufficiency like intrauterine growth restriction. It can present with Doppler changes. Because of all these abnormalities, APLA syndrome was found to be a very important or a basic pathophysiology in women. And all of this pathology is based on only one point, that is cellular destruction. Hence, proved all the pathology, all the pathogenesis starts at the basic unit of life, that is the cell. Hope it was useful. Thank you for watching.